Hi, everyone. Welcome back to the Queer CME podcast. I'm super excited to have Bex on, who we've known each other for a little while, but I usually like to let my guests introduce themselves. So I'll let you go and tell everyone who you are.
Okay. My name is Bex Canner, pronouns they, them. I identify as genderqueer. Sorry, I'm looking at notes. I wrote all this down. um, what do I identify as? Non-binary trans man, and I'm a family physician. I retired from clinical practice in 2022 for a variety of personal and health reasons. I'm joining you from Aotearoa, New Zealand. Aotearoa is the indigenous name for the Māori land that was colonized by people in the 19th century. So relatively recently, but anyway, so New Zealand. I left New Zealand in 2022 to go back to the States for a period of time that at the time was undefined, but ended up being 3 years, and came back here because of issues related to the current regime. And prior to that, I worked in youth health and provided a lot of gender affirming care, and was also involved a lot in some of the political and policy and just an educational space. And now mostly in my professional life, that's mostly education for primary care providers.
Huh. Can you tell us
So,
more about what care was like before you went back to the States? So I guess pre 2022 for adolescent gender affirming care in New Zealand, which you were a big part of developing. And just for our audience members and our listeners, because a lot of our listeners are prescribers in the United States, if you haven't heard, New Zealand banned adolescent gender affirming care as a country. Yes.
puberty blockers
Puberty blockers.
in particular, which I can talk more because there's been some development since I last
Oh,
contacted you about that.
okay. Well, we will all learn something
The
more,
pro or con.
but for all of us who haven't been there and don't know what it was like before and then kind of what has happened, can you set the stage of what it was like before for us?
Yeah. So I don't know how much I need to talk about the health system here, but I'll allude to some of that because New Zealand has a national sort of public health system, but it's regionalized. And so they have what people unfortunately refer to as a postcode lottery in some ways, like where you live kind of dictates a bit about what kind of care you can receive. And I was in Wellington, which is the capital. It's a big city. And there was, in theory, access, there's access to top surgery, but then there wasn't. There was a surgeon who could do it. And then with COVID, he left town or something. I don't know. So there is also a private system if you have money or health insurance, which is for most trans people unusual. So as far as the hormone therapy, when I was practicing, it was very much family physicians typically would refer patients for a readiness assessment. This was actually, I think, in the guidelines, and then that shifted a bit before I left to a psychologist and then to an endocrinologist and then back to the GP for ongoing prescribing. And for puberty blockers that required a child and a pediatric endocrinologist, there was a shift toward training GPs. And I know in the States, the term general practice is not favorable, but that's basically, it's the specialty here that's equivalent to family practice or family medicine in the US. So to move toward an informed consent model where family physicians could get the training to do their own assessment and initiate hormone therapy to trans people of all ages, basically. And as far as puberty blockers, I don't think it has kind of moved to that level yet. That most GPs were still referring young people to endocrinologists. So that's kind of where things were. There was a more liberal government in place at the time, a lot more sort of at least lip service to the unmet need. There's a survey that was done twice, once in I think 2017 or 2018, and then again a follow-up in 2022 called Counting Ourselves. I can send you the link if you want to include it. It's a really good survey of of trans and non-binary folks in New Zealand to demonstrate the unmet needs in all of the regions. In some regions, there aren't any GPs or specialists who provide gender affirming care, and then people have to travel, or there may not be access to publicly funded care. As far as bottom surgery, there's now one surgeon. There was no surgeon for a long time because the one surgeon retired. Now there's one plastic surgeon who's self-trained, basically. She went around the world for 2 years training to do gender affirming surgery. And she said she needs at least 2 or 3 of her to meet the backlog. And I don't know if I feel like I'm kind of all over the place here, but so that's how it was. And then in 2023, this much more right-wing government was elected in, and it's a coalition government with a couple of really right-wing parties, and the leader of one of them was super gung-ho about passing as many anti-trans laws. The government is very much wanting to follow what the US is doing, which is terrible. But I don't think there's going to be, hopefully there's not going to be the uptake of support for banning care entirely. But this guy was we're gonna ban, what do they call it? Mutilation of children's bodies. And of course not understanding what puberty blockers do or anything like that. And none of it's obviously evidence-based. But so in the point, I left New Zealand thinking things were moving kind of in a good trajectory toward more care, more funding, more access. And then I came back and it's as soon as I came back, I went to a peer review group of previous colleagues and just listened to people talking about what's available. And it just felt like it had just gone backwards, which was really sad. The PATHA is the Professional Association of Transgender Health Aotearoa, the local, the New Zealand branch of WPATH, submitted their updated guidelines to the Ministry of Health a year ago or so. And that all got tied up with this, we want to ban puberty blockers. And so all the doctors are, waiting on what's going to happen with that. And in November, after the guidelines had just sort of been sitting with the Ministry of Health, the Minister of Health has no medical experience whatsoever. He's a young Baptist minister. It's no qualification. Came out with this declaration that we're banning all prescribing of puberty blockers for trans young people. Now, if you need them for precocious puberty or other situations for cis kids, that's fine. So it was clearly an anti-trans, and I'm not entirely familiar with the political structure that allows them to just make this announcement without any legislation, but there's something that allows that. And so, yeah, that's what happened. Meanwhile, there's still huge disparities regionally and also obviously economically with what people can access in different parts of the country and what surgeons are available and GPs who have the skills or the confidence to prescribe hormones. There's just, if you're in Auckland, you have better access than regional, rural areas, but it's not just based on the urban versus rural. Yeah, there's still that. So, do you want me to go into what's happened since then, or?
No, this is very helpful. Thank you so much for sharing all of it so far. But I guess before this administration that's there now, was there ever a centralized gender clinic in Aotearoa, or was it always kind of peds endocrinologists here and there that would provide care?
No, there wasn't a centralized clinic. There were different regions that, and basically they'd be, some that are nonprofits that get support from the government or support from the community, or sometimes private practices that would provide that care, but no as such centralized. I mean, it's a small country. You'd think there could be, but there's 5 million people.
And then
No.
for the private practice and public health systems, those are like totally separate. So if a provider works for the public health system, they don't take private insurance at all.
No, there are providers who do both. GPs are pretty much always in the public system, publicly funded. The endocrinologists, the surgeons, they can do both. So the plastic surgeon that I mentioned does both. So I just read this statistic the other day, but it's not entirely current. The quarterly report on the Ministry of Health website, the last one was April 2025. For gender affirming genital surgery, nice acronym. Anyway, there is about 300 there as of April last year, 300 people on the wait list, and they have funding for about 14 surgeries per year. So it'll take 20 years to get through that wait list. Of course, there'll be more people added to the wait list. So it's still pretty dire as far as that goes. But she does do surgeries and take private patients if you have, I don't know, $50,000 or $60,000, I think is what it is now. And then the people who do top surgery, there's a lot more of them in private, and who some of them do work in the public system as well. But the thing is, there just isn't a lot of funding for that. And also, there just isn't the skill set. It's not just something that any old like plastic surgeon, at least we hope not, um, want people that have the skills. And I think people who have the interest in that end up going overseas and not coming back.
Okay.
So
Well, thank you for clarifying a little more about the health system there. It's really helpful. So, whichever puberty blockers are available, the Ministry of Health bans them in November. And then what has happened since then?
So it was November 19th, the announcement came out. It was actually a real shock, because the GPs, we thought, there would be some kind of restrictions on prescribing or something, but not an outright ban. So, and there was a 1 month, it was going to go into effect December 19th. Anybody who was already receiving them could still receive them. So it was new prescriptions that were banned. PATHA went immediately to work filing with the court system, which isn't a commonly used avenue. But in this case, this is just cruelty. This is just, bias. It's not based in science. It's not based on anything that we submitted to the Ministry of Health. They cited the CAS report, which of course we know has been discredited. So just in time for the December 19th deadline, the court issued a temporary injunction saying, this can't be enforced because it doesn't seem to be appropriate, but we're going to do further investigation. So that was great news. But meanwhile, Christmas happens and people don't, there's like a shutdown of not shut down completely, but like nothing really happens for like a month. And there was a lack of clarity on whether that meant that prescribers could go ahead and keep prescribing, or whether they had to like wait until the final ruling. So today I just got an email from PATHA and said, because of this lack of clarity, they're going to court on Monday to ask for that clarification. And then the final decision is in May, sometime in May this year. So hopefully what will happen is they'll say, yes, we meant that you can keep prescribing until we make our final decision, because that was kind of the implication from that ruling. So at least the courts are kind of on board with like, this doesn't seem to be a scientifically backed decision. This is a politically motivated decision. So
Yeah.
hopefully that'll,
And it was only puberty blockers. They didn't ban hormones or other
no,
medications.
yeah. I mean, they right now is the I don't know if this is a hard and fast rule, but it tends not to be prescribing of cross-gender hormones until about age 16. So puberty blockers are kind of the only available hormonal measure right now. And they didn't ban care in general for adolescents or adults. You could say, well, that's only a matter of time if this government gets back in. There's an election this year, so we're hoping it's not. It's they don't, but yeah. So that was the only thing currently that has been.
And then, yeah, is there a kind of age are you aware if there's like an age distinction in New Zealand for like when you become an adult and are able to access care?
Typically, it's 16. There is in general kind of a, I don't know what you call it, not exactly policy, but recommendation, I guess, that a child of any age, if you really have a good sense that they are able to consent, I mean, they could be 13, depending on the situation, or, typically, I think it seems that gender affirming hormones and surgeries don't sort of happen until at least age 16. That, and, in the, even in the informed consent process, that's kind of the general feeling. I don't know for sure if it's actually, like, against any guidelines or rulings that a younger person could access hormones of some sort, but I don't recall actually prescribing any hormones to anybody under 16 other than puberty blockers.
Yeah. WPATH has like removed the age restrictions rate and just
Mhm.
recommended that's an individual decision.
Yeah, yeah.
Friend Society, I think they still have age 16 in their recommendations. You know, that age 16 came specifically from the Dutch trials, right? So like it was just what was studied back then. And so then of course when that's what we have studied, that is what we tend to pull forward and rely on.
Yeah, and there's some things that New Zealand's doing that aren't quite in line with WPATH, like progesterone, for instance. They're not really in line with the recommendations, especially around informed consent. I don't know why. I haven't been able to figure out. I've asked this question many times to the endocrinologists and to other people who are like, it's not in the guidelines for feminizing hormone treatment. And I'm like, is there a harm? Because if there isn't a harm, there's many medications that we give people that
Yeah.
have harms, and as long as you're informed, I still prescribed micronized progesterone with that in mind, but
Yeah, I think WPATH actually still says that they can't recommend for it because there's not enough evidence. However, I have some critique of WPATH suggestions there. I think their primary concern being the theoretical risk of breast cancer, which, the data that we have on breast cancer risk with micronized progesterone is that we don't see an increased risk in cis women. We don't know in trans folks. And we don't have like really long-term data on cis women, but we have pretty solid set. And then, that increased risk of breast cancer really comes from progestogens, like the things we put in birth control pills.
yeah.
I think it was a theoretical concern based off progestogens, but like the more we know about bioidentical hormones versus synthetic, the more the data seems to suggest that they don't carry the same risk profile, and we can't equate that risk profile. I do think there's one small study on micronized progesterone in trans patients that looked at like did breasts get bigger over a 3-month time period, and it said they did not. There's another really small study that looked at breast development for like a 6, I think, to maybe 12-month period. But in addition to like, they also asked patients if they were more satisfied with their breast development, and patients were, which I think is a really big distinction because I do think a study that just asks if someone's tits got bigger is like very misogynistic.
Mhm. Exactly.
like, like that is concerning to
Sure,
every
that's what you want, right?
feminist bone in my body. And then there's a really large study, like much larger than either one of those, that was done in Europe that the results aren't published, but they were presented at EPAC. And that they found that there was actually increased breast size development with micronized progesterone. And so and I think that like that had, I want to say, thousands of data points. Like it was a much larger study. So,
Yeah.
um,
I think
yeah,
the New Zealand guidelines are more firm, even more sort of firmly against than WPATH even, so
yeah,
that's
yeah,
been frustrating because I think I think the data is based on the like Provera synthetic
Yeah,
risk.
I have like a couple of TikTok videos up where like I fall into a deep rabbit hole of like what were the WPATH references for like being for these concerns and like looking at those references. And then it was like that paper that was referenced was actually like wasn't any new original research. It was actually like, right, some kind of like meta-analysis or something where they collected a bunch of other papers. And so like I went back to all the original papers that like one of which was from like 1970s.
Mhm.
Like you know, and so and I think I like to get the details utterly correct, I would have to go back to my TikTok video, but like basically the vast majority of cases that were represented in that data were on medroxyprogesterone or like cyperterine. It was not micronized progesterone. So I'm like, that you are making a point with data that does not actually support your point at all. So, but I've derailed us completely.
Going down a rabbit hole here. So anyway,
Derailed progesterone prescribing. But no, absolutely. If any of your colleagues in New Zealand would like to do education on micronized progesterone and like fall into a nerdy science hole, I'm always available. But yeah, I think yes. Okay, so we have the updates are it was the puberty blocking decision was enjoined in court, but we're not actually clear on what that injunction meant. So we're going to get some clarification soon,
mhm.
we hope. And then that actual case will be decided this late spring. Well, I guess seasons are different there because you're in a different
Yeah,
hemisphere.
autumn. Yeah, it's summer right now. I'm just gonna really quick look at the date on that. Yeah, 6th to 7th of May is when
Okay.
the hearing is scheduled. So,
Yeah.
um,
Okay. Okay. And, like you're feeling optimistic that like the court feels seems more rooted in the science and the evidence.
I am cautiously. Yeah, I mean, the initial injunction seemed to be based on, from what we can tell, there's no harm, that the government's wrong, that these medications are harmful, and that that will actually do more harm to young people to withhold them.
Yeah.
And there's been a lot of, I mean, there were a lot of submissions, and letters, and internationally as well as within New Zealand from different nurse practitioners and Māori health providers and of course general practice, and about the harms that this is going to do to young people. And I have friends who had young children who are trans, like
Mm.
7, 8 years old, who were like devastated because they think there's nothing, that's going to allow them to go through puberty or not go through puberty until they are able to take the hormone that aligns with their gender. And of course, in terms of AMAB people, that's especially devastating, 'cause,
Yeah,
um,
there's more not to again derail us into like a clinical practice standpoint, but there's a few small studies looking at raloxifene, which is a selective estrogen receptor modifier,
mhm,
which blocks estrogenic activity at the level of the breast and the uterus for supporting people with ovaries who are younger and unable to access puberty blockers. Puberty blockers are the gold standard by far, right? Like that's where our research is, that's where our data is, and really they're so safe and well tolerated compared to like most medicines we use.
mhm,
Really
yeah,
like I feel like there was like a endocrinology quote about just like how like if all of our medicines can be this effective and this safe, right? So definitely like some of these alternative strategies where you might look at something like raloxifene or anastrozole, um, where we don't have the research and data and we don't have the safety data, like aren't going to be the right solution for all families, but they might be the right solution for some families.
yeah,
Yeah, and then I'm I'm presenting on serum specifically soon. So I was like recently in the data on this, but it is one I've used for adolescent care and really specifically like when I could not access puberty blockers or when I had someone who had like we were worried like their puberty blockers was going to give them their first period and like we were really worried how that would impact their mental health. And so we've used it to try to like prevent that during that surge you get with a GnRH agonist. Yeah. And also I've had adolescents who also like we've used Relaxofene where we're like waiting to access puberty blockers because like the weights have gotten like prior authorization approval in the states, even in states where care is legal and protected, are just like slower than they used to be and harder. And so I'll oftentimes offer that to families like while we go through this prior authorization process. And I've actually had adolescents who've had like breast bud reversion with that, which is a medication that's been used to treat gynecomastia in cis populations. So I've headed to Real Dust and I wanted to like specifically ask about something. Oh, I was gonna clarify. Do you know anything about the court structure in New Zealand and the context of like if you win or lose at this level of court, is there another level of court to go to, or is there just one level of court? I don't know anything about it.
Yeah, I looked this up because I'm not entirely sure. And there's a high court. It's basically the high court. There is a Supreme Court, I think, above that, but I'm not 100% sure sort of what kind of cases they hear. But the high court, as opposed to like district courts or regional courts, hears cases that, severe crimes like murders and violent, whatever they identify as severe, and also legislative issues of like legislation or government action that might be illegal and potentially very harmful, like the situation. I mean, the first win was getting them to hear the case. You know, um, I guess it's a little bit like the court system in the U.S. in terms of like being able to overturn laws or that are not constitutional. Although New Zealand doesn't per se have a written constitution, but so that's a little bit confusing to me. But yeah, I don't know if there's another level if they can go to the Supreme Court if it's not successful, or yeah, I'm not entirely sure about that. It's something
Yeah,
it's
yeah.
not growing up in New Zealand. Even if I had, I might not have learned that. But
I didn't fully understand like our U.S. court system honestly until I got subpoenaed by the Department of Um, so I mean, obviously, like I took it I took it in classes in elementary and middle school and things like this. But then, like we specialize so intensely in like healthcare, right, in medicine, that I feel like a lot of that earlier education there was no more packing room in my brain, and so it had to be
yeah, well, I asked my partner who grew up in New Zealand, and they didn't know either. So
right. In some ways, I often think about how, for me, this is like a component of white privilege too. Like, I didn't have to understand the court system because I was never really afraid of going to court.
right, yeah,
And so I think about how different my life experience has been because of that and what a privilege that is. And I'm fascinated. I'm curious. So we're like waiting for this case result. I think I was really curious to have you on the podcast because I have had so many families of adolescents like moving to safer states from less safe
hmm
states within the United States, and then other families moving from the United States to other countries. And also then one of my like folks I know up in Canada had a really lovely conversation with me about how like when there's a place that's better or worse, we don't work as hard to fix where we are. Which I thought was really, really interesting perspective. How, as a Canadian, oftentimes like, well, we're not as bad as the States,
yeah.
so they don't like make as much progress or change. And then for us in the States, like actively leaving. And I think when I heard the news in November about the prohibition on puberty blocker prescribing in New Zealand, right, it was also at that same time in November. Gosh, like when did Children's Hospital LA announce that they were no longer providing gender affirming care? There were several, I feel like right around in that like October, November, December time, there were a lot of large academic clinic closures in the States.
hmm
And then there was like the massive attack on funding, right? And just I think, is sitting for me in that process was like that if clinicians work in compliance with like fascism and hate and transphobia, there will be nowhere safer to go eventually. Like there, yeah, I think that is kind of what that news from New Zealand, because like really held for me also in like watching so many families trying to migrate to like Washington or Oregon or California or Massachusetts and then have these clinics in these places close and stop providing care and have the federal government in the United States go after funding it. Just like really felt like it is it is such a privilege to be able to go to safety, and for everyone who wants and needs and can make that choice, like I don't think I like make it do it. I don't
Mhm.
think my because I've like been making similar choices, and one of the people close to me was like, Crystal, no one is like mad at the people who left Germany and survived,
Yeah.
and for so many people, they don't have the privilege to make that
Yeah.
choice or to leave. And then for so many people, they don't want to, right? Like you're leaving
Uh-huh.
behind so much when you do that. And ultimately, like I think it's so essential for clinicians to like m- make that choice in accordance with their ethics, not with accordance of like and with the evidence and with like the like standards of care, the evidence, but most importantly, ethically. And so I think that was a big part of just what I wanted to like bring to the table when we talked on this episode of the podcast is just like how there's so much more early compliance that is deeply problematic, right, in the States. And I think any compliance contributes to the genocide of a generation of trans children and like contributes to the spread of misinformation. Yeah. And transphobia.
Mhm.
So yeah.
Yeah. Yeah. And what I read from the States is there's people who feel really emboldened in their prejudices, whether it's racism or transphobia, what do you call it, xenophobia, whatever it is, that it may have been under the surface, but now they feel like it's just fine to sort of express that. Yeah, and I'm really aware that yeah, privilege is a big part of it. And I mean, I actually am a dual citizen and never really intended to go back to the US. And then with COVID, I was separated from my daughter and then my partner wanted to have a change of life. Just Kiwis seem to idolize the US for some reason. Maybe not so much now, but so I knew there was always that sort of safety net in a way that other people don't have. So I could come back here and slot into, the health system and everything. Because that's one thing is like you can't just sort of move somewhere and expect that you're going to be able to kind of access healthcare in another location if you're not a citizen or have the right kind of visa or whatever. And then of course there's the socioeconomic barriers and which dovetail with racial, ethnic identities. And so it's not lost on me that this is an incredible privilege that I have to be able to leave there. And we see that here, obviously, if people aren't as able to access private healthcare if the public system isn't providing what they need. Now, in this case, I don't think that this government edict is going to matter whether you're a private practitioner in the public system. It's not a funding issue. It's a kind of legal issue. So any alternative practice to that would be kind of underground or in the black market. Is
Trans people have been taking care of trans people and like they're right doing DIY hormonal care uh since the dawn of time.
Yeah.
Right. I feel like some of the name is fucking perimenopause. Really phenomenal transhuman who writes a lot about the history of trans healthcare. I think I'm thinking of Jules Dill Peterson. And so yeah, they're just like I feel like maybe it was Kate's work, maybe it was Jules' work. Now I'm gonna get everyone confused. But it just like read back through someone's like really succinct. I think it was actually the an amicus brief that was submitted for the Tennessee case um to the Supreme Court. And there was like a succinct history of like transgender healthcare interventions, you know, that like talked about like breast surgeries and like before we were I think before there was like a number in front of the number, so like 800 something, you know, there was not there was not a double digit, you know. I'm not making a lot of sense. I'm not a historian. But and like but really fascinating, like but you know, trans people have been taking care of trans people for an incredibly long time.
Yeah, and I feel like, there has been a lot of pushback, and it's interesting because before I came on, I'm just like, I'm gonna look at New Zealand First is the name of, ironically, the party that is particularly spearheaded this move, and that's I don't know if you noticed my shirts. The guy who's the leader of that party called people like us extremist lefty losers, and these shirts were a fundraiser for PATHA to pay for court costs. So that's why I'm wearing it today. And to see what New Zealand First has come out with since this court injunction, and there isn't anything, like they haven't responded. So it's not like, now there's this big like, oh no, we have to, fight this. It's just like, oh yes, we've won, and now we're winning, hopefully. But there's also a lot of nonprofits, organizations that are raising money for people to pursue other alternatives. One of which for New Zealand citizens is to go to Australia, which currently is a little bit more progressive in this area at the moment, because we can get New Zealand citizens have the right to work in Australia and have the right to healthcare in Australia. But obviously that costs money. So some of that is, to try to help people who really need to get out of here, at least for a period of time, so they can access care. I mean, there are people who, crowdfund or whatever I have a friend who went to Thailand for her gender affirming surgery. Seems expensive, but apparently it's still cheaper than doing it here. There's also other barriers like BMI requirements. And I think that's just gatekeeping so that they can have some kind of way to weed out people. And apparently, I think that was one of the reasons that she went there, is that she couldn't get into the system here because of that. So that's another rabbit hole to go down. Yeah. So underground civil disobedience. I mean, those are all options. I don't think Kiwis are prone to sort of making waves, but there are protests. I mean, there was a huge protest to Parliament about this, which is great. And there's a Māori tradition called hikoi, which is like, I think it's kind of like the Buddhist monks who are like walking to Washington or something that I saw something about. But just taking a huge walk around the country and gathering people together to go to the Capitol, say to Parliament, and deliver your but it's like a ritual kind of thing. So those kinds of things have happened for a variety of different issues, but including this one. So there is action, community action, and definitely GPs who are standing up and going, no, we can't tolerate this. We're not just going to take this lying down. We're going to do every avenue that we can. So that's good. And PATHA, the membership of PATHA is not just doctors or healthcare providers too. So there's a lot of, community organizers, activists, and
Yeah,
things involved. So that's
absolutely.
something anyway.
Yeah. Well, thank you so much for coming on and sharing about your experiences and what's happening there. I think it's the world is like such a local and such a global place. It's like such a interesting time to be alive, although that's kind of been true for a long time now. And I think just, yeah, understanding the bigger picture can be so beneficial. So I really, really appreciate your time and sharing with us.
Oh yeah. Thanks for inviting me. It's always good to be able to share what's going on around the world and my little part of it.
Is there anything else you would like our listeners to hear before we sign off?
No, just hold fast to your keep the fight up. I mean, I don't know exactly how to put that, but
Mhm.
you know what I mean. Just
Yeah.
don't
Yeah.
don't comply in advance, etc. Just
Persist in your resistance.
keep doing what you're doing. Yeah.
Amazing. Thank you so much, Bex.
Yeah. Thanks, Crystal. It's great to see you again.